The accurate assessment of the functional integrity of prosthetic heart valves is a clinical challenge that can be answered comprehensively with echocardiography. As with native valvular stenosis, the addition of Doppler has been a tremendous advance in delineating the hemodynamics of prosthetic valve function and dysfunction. The more recent application of flow imaging and transesophageal echo to the study of prostheses has been particularly useful for assessing prosthetic regurgitation. By using an approach which integrates all of these modalities, we can completely solve most diagnostic problems related to valvular prostheses. The study of prosthetic dysfunction is complicated by the large variety of prostheses, each of which comes in numerous sizes and can be implanted as replacement for each of the 4 native valves. In addition, there is a large variety of pathology that can beset the patient with a prosthesis. Prosthetic valve stenosis can result from a prosthesis that is undersized relative to the patient, or can result from structural abnormalities such as thrombus formation or pannus ingrowth. Prosthetic regurgitation can be either perivalvular or transvalvular. This latter, for mechanical prostheses, can result from thrombus that prevents the poppet from seating properly, or from variance in the shape of the ball or disc. For bioprostheses, transvalvular regurgitation usually results from leaflet degeneration. Both perivalvular and transvalvular regurgitation can result in shearing of red cells with intravascular hemolysis. Finally, prosthetic valves are subject to infective endocarditis and all of its sequelae, including valve ring abscess. Cardiac symptoms arising in patients with prosthetic valves may not necessarily be due to the prostheses. In addition to fully characterizing prosthetic valve function, a complete echocardiographic exam will define associated lesions of native valves, chamber sizes and ventricular function, pulmonary artery pressure, atrial thrombi, and pericardial effusion or hematoma. Challenges facing the echocardiographer in assessing prosthetic valves include difficulty in imaging prostheses by 2D echo because of the dense sewing ring and dense reverberations from the prosthesis. Furthermore, poppet excursion on the 2D exam is in part dependent on how the prosthesis was inserted. Color flow imaging of prostheses is difficult because of attenuation of the sound beam by the prosthetic material, which can create flow masking. From a hemodynamic standpoint, it is necessary to establish whether or not the simplified Bernoulli equation can be applied to prosthetic valve gradients, and it is necessary to establish normal values for the many different types and sizes of prostheses. We will begin our discussion with normal prosthetic valve appearance on the 2D exam and normal color flow imaging. We will then discuss validation of the simplified Bernoulli equation for prostheses, and we will illustrate normal prosthetic valve hemodynamics. The discussion of normal hemodynamics will be followed by a discussion of pathologic prosthetic valve stenosis. Next, we will illustrate a systematic approach to prosthetic regurgitant lesions, and we will conclude with a discussion of valve ring abnormalities. We will begin our illustration of normal prostheses with the ball cage variety. This 49-year-old female has Starr-Edwards mitral and aortic prostheses. Throughout this tape, we will use this type of abbreviation to indicate a prosthesis, which in this case is a mitral valve replacement. This is the sewing ring, and this is the tip of the cage. This is a systolic frame. These echoes represent the leading edge of the ball within the cage. This is the trailing edge of the ball. From this image, the ball appears to be elongated with a large portion outside the cage in the left atrium. The ball is displayed like this because echocardiographic instruments are calibrated to measure distances according to the speed of sound through tissue. Since the speed of sound propagation through the prosthetic material is significantly slower than the speed through tissue, therefore the poppet is displayed with this artifactual elongated appearance. In this diastolic frame, echoes are noted in the left atrium. These are reverberations from the prosthesis. Each type of prosthesis has its own characteristic reverberations. As each prosthesis is inspected, the echocardiographer should determine if there are any other extraneous echoes that might represent vegetations or thrombus. In addition, the echocardiographer should see if poppet excursion is normal and if the sewing ring is stable and free of rocking motion. Motion of prosthetic valves can be precisely analyzed using M-mode. This recording was made from an apical transducer position with a sound beam directed at a Starr-Edwards mitral prosthesis. This is the leading edge of the ball in systole, and this is the trailing edge. Here the ball is moving toward the apex to its open position, and here it is closing again with the next systole. Opening and closing clicks are recorded on the phonocardiogram. Returning to the 2D exam, we will demonstrate normal color flow imaging for a mitral Starr-Edwards prosthesis. Blood from the left atrium enters the left ventricle around the ball in the form of a jet or spray. In 2 dimensions, this spray has the appearance of a pair of horns surrounding the ball. Note that there is no evidence of mitral regurgitation. Prosthetic valves should always be scanned from multiple tomographic planes. Here the transducer has been tilted inferiorly to image the inferior portion of the sewing ring. The sewing ring does not appear to be separated from the mitral annulus, and there is still no evidence of regurgitation. Now we have narrowed the 2D sector to increase the frame rate and more clearly delineate flow through this mitral ball cage prosthesis. This is the same patient. The transducer has been rotated to develop this apical long axis view. This is the mitral prosthesis, and this is the aortic ball cage prosthesis in diastole. This is the leading edge of the ball. Aortic prostheses are typically more difficult to image than mitral prostheses. Poppet motion is identified via the to and fro motion of the mass of reverberations within the aorta. The transducer has been tilted slightly to inspect the aortic sewing ring. There is no evidence of dehiscence. Flow imaging demonstrates a jet which travels around the ball and into the aorta. This flow below the aortic prosthesis in diastole represents the normal antegrade flow through the adjacent mitral prosthesis. There is no prosthetic aortic regurgitation. This 52-year-old female has an aortic Starr-Edwards prosthesis, which is being imaged with the transducer in the suprasternal notch. From this position, the jet originating from the prosthesis is more clearly delineated, since the ultrasound beam does not have to cross the prosthesis before encountering the jet. This is an apex-down, 4-chamber view from a 62-year-old male with mitral and tricuspid Starr-Edwards prostheses. The mitral and tricuspid poppets are moving freely. The transducer has been tilted inferiorly to image the tricuspid sewing ring. There is no evidence of dehiscence. This 63-year-old female also has mitral and tricuspid Starr-Edwards prostheses. She had severe tricuspid regurgitation prior to insertion of the prostheses. On this scan at the level of the tricuspid sewing ring, note the marked enlargement of the coronary sinus due to the previous severe right atrial hypertension. Flow across the tricuspid prosthesis is normal by color Doppler. This is a transesophageal echo from the same patient with mitral and tricuspid Starr-Edwards prostheses. In early systole, color flow imaging demonstrates flow into the left atrium directly above the mitral prosthesis. This is the normal closing volume of the prosthesis, the volume of blood displaced by the poppet as it closes. In real time, you will see that the closing volume appears only in early systole. It is not holosystolic. Now we are directing attention to the tricuspid prosthesis. In early systole, we again appreciate the volume of blood that has been displaced by the prosthesis into the right atrium. In real time, this closing volume will appear as puffs of color within the right atrium. It is important to distinguish the closing volume from pathologic transvalvular or periprosthetic regurgitation, both of which are holosystolic. This 42-year-old female has a Bjork-Shiley mitral prosthesis and a bioprosthesis in the tricuspid position. At this time, we will focus attention on the mitral prosthesis. This is the sewing ring, and this is the disc in the fully opened position. In systole, A characteristic rectangle of reverberations is seen in the left atrium behind the closed disc. Note that the patient's prosthesis is normally functioning, but LV function is severely reduced. This 30-year-old female also has a mitral Bjork-Schiley prosthesis. This is a normal color jet from antegrade flow across the prosthesis. In this diastolic frame, the open disc creates a small filling defect within the color map. Flow occurs through both the major orifice and the minor orifice, and then the two jets merge into one as they pass the tip of the disc. This apex down 4-chamber view is from a 69-year-old female with a St. Jude mitral prosthesis, which has two metal discs. In systole, there is a block of reverberations in the left atrium behind the closed discs. This is similar to those which we saw with the Bjork-Schiley prosthesis. In diastole, we see both discs opened, with linear reverberations behind each disc. There is moderate left atrial enlargement and mild right atrial enlargement. The left ventricle is normal in size and function. We are now using the regional expansion system to more clearly visualize the motion of the discs. In this diastolic frame, the discs are fully opened. In real time, you will notice that the lateral disc closes slightly before the medial disc during several cardiac cycles. By capturing several cardiac cycles on cine loop, we can use the trackball to investigate disc motion frame by frame. This study is from a 56-year-old female with a Carpentier-Edwards heterographed mitral prosthesis. The stents are usually oriented toward the septum. As with mechanical prostheses, the echocardiographer should answer several routine questions during evaluation of a bioprosthesis. Are there any extraneous echoes that might represent vegetations or thrombus? Are the leaflets normal in thickness? Do the leaflets open fully? Is there any prolapse or flail motion beyond the sewing ring? Is the sewing ring stable, or is it separated from the annulus and rocking? Here, left ventricular size and function are normal. The left atrium is moderately enlarged and free of thrombus. This is the 42-year-old female whose mitral Bjork-Schiley prosthesis was previously demonstrated. At this time, we want to direct your attention to the normal Ionescu-Schiley heterograph prosthesis in the tricuspid position. Although the cusps appear somewhat echodense, the opening is normal and there is no prolapse. This 73-year-old male also has a tricuspid heterographed prosthesis. The color flow image in diastole is identical to that of mild tricuspid stenosis, with a central blue zone representing color aliasing. This is due to the small gradient created by the prosthesis. Incidentally noted is trivial regurgitation across the valve. The right atrium is moderately enlarged without thrombus. A fresh frozen aortic homograft prosthesis was selected for this 21-year-old male. In this apical long axis view, you will see normal opening and closing of the aortic cusps. Left ventricular size and function are normal, and note also that the mitral valve is normal. By now, you have appreciated that it is much more difficult to image prostheses than it is to image native valves. This is particularly true for the mechanical prostheses with their multiple reverberations. The addition of Doppler has therefore been exceptionally useful for the evaluation of prostheses. Prior to discussing examination of prostheses by spectral Doppler and normal values for prosthetic valve gradients and orifice areas, we will detail the verification of the simplified Bernoulli equation for prosthetic heart valves. On previous tapes in this series, we have demonstrated use of the simplified Bernoulli equation to assess stenosis of native valves. We can apply this same equation to the study of prostheses. In a Mayo Clinic study, Dr. Darrell Burstow performed continuous wave Doppler examinations of prostheses, and the velocity spectra were recorded simultaneously with pressures from invasive catheterization. The study group was made up of 36 patients with 42 prostheses. There were 20 mitral and 20 aortic prostheses, as well as 1 tricuspid and 1 pulmonic. There were 32 mechanical prostheses and 10 bioprostheses. The mechanical valves included 15 Starr-Edwards, 7 Bjork-Scheile, 4 Braunwald-Cutter mitral prostheses, 2 Hall Medtronic, 2 St. Jude, 1 Sorin, and 1 Smiloff-Cutter. This record is from a patient with a Starr-Edwards aortic prosthesis. As with stenosis of the native aortic valve, Doppler will not provide the peak-to-peak gradient for prostheses, since the 2 peaks do not occur at the same time. As you will recall, the aortic peak is delayed compared to the peak of ventricular pressure. The maximum Doppler velocity correlates with the maximum instantaneous difference between left ventricular and aortic pressures. More importantly, the Doppler mean gradient correlates closely with the mean gradient obtained by catheterization. It is important to realize that in order to invasively obtain the same mean gradient that was measured with the non-imaging CW probe, 1 catheter had to be passed to the ascending aorta, while left ventricular pressure was obtained by either transeptal technique or by direct transthoracic puncture of the left ventricle. For all 20 aortic prostheses, there was an excellent correlation between the catheter mean gradients and the Doppler mean gradients. The R value is 0.94, and the standard error of the estimate is 3 millimeters of mercury. For For 12 of the 20 mitral prostheses, the mean gradient was determined by transseptal catheterization with a direct measurement of left atrial pressure, while a second catheter was used to measure left ventricular pressure. As you can see in this study from a Starr-Edwards mitral prosthesis, the Doppler mean gradient correlates closely with the catheter mean gradient. When a transseptal catheter technique was utilized, the Doppler mean gradients were nearly identical to the catheter mean gradients. The R value is 0.97 with a standard error of the estimate of 1.2 millimeters of mercury. However, the correlation was poor when Doppler mean gradients were compared to catheter mean gradients obtained by using pulmonary capillary wedge pressure instead of direct measurement of left atrial pressure. For these 8 patients, catheterization significantly overestimated the true mean gradients. The overestimation of mitral prosthetic gradients by catheterization using pulmonary capillary wedge pressure is illustrated by this case. This patient was identified as having a 9 millimeter mean gradient across a 29 millimeter Bjork-Scheile mitral prosthesis, using the difference between pulmonary capillary wedge pressure and left ventricular pressure. However, the mean gradient was only 3 millimeters of mercury by simultaneous Doppler evaluation. Note that the Doppler pressure half-time was also normal, 80 milliseconds. When left atrial pressure was directly measured using a transseptal technique, the mean gradient by cath agreed with the mean Doppler gradient, both at rest and following pharmacologic increase in the heart rate. Therefore, in order to invasively obtain the same mean gradient that can be measured non-invasively with CW Doppler, puncture of the atrial septum must be performed. Use of the wedge pressure can lead to serious overestimation of the mean mitral gradient. These are the combined results for all prostheses, mitral and aortic. The Doppler and catheter mean gradients had an R value of 0.96 and a standard error of the estimate of 3 millimeters of mercury. For aortic prostheses, we utilize spectral Doppler to obtain the maximum velocity, which correlates with the maximum instantaneous gradient, the mean transvalvular gradient, the dimensionless obstruction index, which is the velocity in the LV outflow tract divided by the maximum velocity, and the effective orifice area. We will now illustrate these measurements. This patient has Bjork-Scheile mitral and aortic prostheses. As usual, it is difficult to clearly delineate the aortic disc. The non-imaging transducer in the apical position has been directed toward the aortic prosthesis. These are the opening and closing clicks. The maximum velocity is 3.5 meters per second. In this freeze frame, the clicks from both prostheses are recorded. Mitral closure, aortic opening, aortic closing, and mitral opening. The aortic velocity spectrum has been traced to obtain the mean gradient, which was 27 millimeters of mercury. This is in the high normal range for a 21 millimeter aortic tilting disc. In 1988, Reisner and Meltzer reviewed the literature for Doppler evaluation of prosthetic heart valves in patients who were clinically normal. They published the accumulated data for over 1,000 prostheses. Of these, 494 had aortic prostheses. The maximum instantaneous gradient had been calculated for each prosthesis using the simplified Bernoulli equation. This is a comparison of the mean value and standard deviation for for the maximum instantaneous gradient across several different types of prostheses. Included are Starr-Edwards, St. Jude, Ionescu-Shiley, Bjork-Shiley, Carpentier-Edwards, and Hancock. As you can see, the maximum gradient across Starr-Edwards valves is, in general, higher than the gradients across each of the other valve types. When evaluating the hemodynamics of prosthetic valves, it is important to be mindful of the valve size. In this graph, Reisner and Meltzer display the peak gradient for 5 different sizes of aortic Bjork-Shiley prostheses. These are the number of patients with each size valve. As you would expect, there is a significant decrease in the maximum instantaneous gradient as the valve size increases. This is a similar graph for a bioprosthesis, the Carpentier-Edwards heterograft. Once more, we observe a significant decrease in maximum gradient with increasing valve size. This same trend was also found for mean gradients across these prostheses. As with stenosis of the native aortic valve, it is important to utilize multiple transducer positions when establishing maximum instantaneous and mean pressure gradients across aortic prostheses. In addition to the apical position, right peristernal positions should be used. For completeness, the transducer should also be placed in suprasternal, left peristernal, and subcostal positions. In each position, fine manipulations of the transducer should be made until the maximum spectral envelope is obtained. Returning to the patient with the Bjork-Shiley aortic prosthesis, you will recall that with the transducer in the apical position, the maximum velocity was 3.5 meters per second, and the mean gradient was 27 millimeters of mercury. Here, the non-imaging probe has been placed at the right sternal border, with the patient in the right lateral decubitus position. In this position, the velocity spectrum was maximized. The maximum velocity is 4.1 meters per second, and the mean gradient is 34 millimeters of mercury. These values are high for a Bjork-Shiley prosthesis, which could relate to either pathologic stenosis or to the prosthesis being undersized for this particular patient. As a rule, once the transducer position for the maximum velocity has been identified, it should be noted in the report. This will facilitate future studies on the same patient. As with the native aortic valve, the gradient across a prosthetic aortic valve is not always clearly indicative of the degree of obstruction. A patient with a low output state can have severe obstruction despite a relatively low mean gradient across the aortic prosthesis. And a patient with a high output state can have very little obstruction despite a relatively high gradient. For patients with reduced or with hyperdynamic left ventricular function, it is particularly useful to calculate the aortic prosthesis effective orifice area. You will recall that the continuity equation is used to calculate native aortic valve area. We can apply this same equation for prosthetic valves. We need to first determine the left ventricular outflow tract area. When possible, a direct measurement of the systolic LVOT diameter should be made from the 2D exam. This is an expanded view of the LVOT. This is the sewing ring of a 21 millimeter Carpentier-Edwards aortic bioprosthesis. The cusps were difficult to visualize in this view. A single cardiac cycle has been captured on CineLoop. A systolic frame has been selected. One cursor was placed at the junction of the sewing ring with the ventricular septum, and the second cursor has been placed at the junction of the sewing ring with the anterior mitral leaflet. The LVOT diameter is 21.1 millimeters. This is essentially the same as the external diameter of the sewing ring. Once the LVOT diameter has been measured, we square it and multiply by the constant 0.785 to obtain the LVOT area. After calculating the LVOT area, we need to obtain the time-velocity integral of flow through the outflow tract. For this, we use the apical long axis orientation and position the sample volume in the outflow tract just below the aortic prosthesis. The examiner must take care not to place the pulsed wave sample volume too close to the prosthetic aortic valve sewing ring. This is an expanded apex down view of the LVOT and ascending aorta. This is the sewing ring of the same Carpentier-Edwards prosthesis that we used for demonstration of the LVOT diameter measurement. Color flow imaging shows the expected jet beyond the prosthesis in the ascending aorta. This is the sewing ring. There are dead water zones near the edges of the ring, which result in acceleration of blood in the central zone, as indicated by the color aliasing. Note that this begins almost 1 centimeter proximal to the sewing ring. For the continuity equation calculation of aortic valve area, we want to measure the LVOT velocity proximal to this zone of aliasing, back here where the velocity is more uniform across the entire LVOT diameter. This is the same patient. The small image is an apex down display of the apical long axis view. The pulsed wave sample volume is positioned near the sewing ring of the aortic prosthesis. The resultant velocity spectrum aliases at 1.5 meters per second. Now the sample volume has been moved to a more proximal position in the LVOT. The spectrum no longer aliases. The patient is in atrial fibrillation and the velocity varies with cycle length. It averages 1.2 meters per second. This is the velocity we would use for the effective orifice area calculation. Having obtained the LVOT area and LVOT velocity, we need the time-velocity integral of flow through the prosthesis. For this, we use the maximum velocity spectrum obtained by placing the CW transducer in the multiple transducer positions that we referred to earlier. In this example of a St. Jude prosthesis, we are illustrating the most common situation where the maximum spectrum is obtained with a transducer in the apical position. This is the CW velocity spectrum across the Carpentier-Edwards aortic prosthesis, for which we have already measured the LVOT diameter and LVOT velocity. For this patient, the maximum velocity spectrum was identified using an apical transducer position. The maximum velocity is 3 meters per second. From the continuity equation, the effective orifice area of an aortic prosthesis is obtained by multiplying the LVOT area times the TVI of the LVOT and dividing by the TVI of flow in the aorta that was obtained with CW Doppler. As with native aortic stenosis, this calculation can be simplified by using the peak velocity in the LVOT and the peak velocity in the aorta instead of the time velocity integrals. For our patient with the Carpentier-Edwards aortic prosthesis, the LVOT diameter was 2.1 centimeters, which yields an LVOT area of 3.46 square centimeters. We multiply this times the LVOT velocity, 1.2 meters per second, to complete the numerator of our valve area calculation, 4.15. This is divided by the maximum velocity across the prosthesis, 3 meters per second, to yield the effective orifice area, 1.4 square centimeters. This 58-year-old male has a Starr-Edwards mitral prosthesis and a Bjork-Shiley aortic prosthesis. It is not always possible to measure the LVOT diameter in the presence of a mechanical aortic prosthesis, particularly if the patient also has a mitral prosthesis. In this situation, we use the external diameter of the aortic sewing ring as an approximation of the LVOT diameter. This patient has a size 25 Bjork-Shiley prosthesis, which means that the external diameter of the sewing ring is 25 millimeters, or 2.5 centimeters. This is an apex up, apical long axis view from the same patient. In order to determine the left ventricular outflow tract velocity, it is important to align the image such that the Doppler cursor can be dropped straight down the screen and be parallel with flow in the LVOT. By properly aligning the image like this, we avoid an angulation error in the measurement of the LVOT velocity. The small image shows the Doppler cursor crossing the LVOT. The sample volume is just about to enter the LV outflow tract. In real time, you will notice an increase in the velocity as the sample volume is advanced into the outflow tract. This sample volume position, just below the aortic prosthesis, is the one we want to use to obtain the LVOT velocity. As previously discussed, if we advance the sample volume too far toward the sewing ring,